Good morning. Everyone can hear me. I'm mic'd up today. You have a wonderful way of welcoming people, so thank you very much for that. It's terrific to see that. I'm going to talk today about designing medication processes for humans. Talk a lot about humans, and you'll understand a bit more what I mean as we go along. So here I am, that's my email address. Feel free to contact us. Feel free to visit our website. Pretty much everything on there is entirely free for people to use. There's things directed towards consumers. There's things directed towards professionals of all disciplines, pharmacists and MDs and healthcare workers and personal support workers and whoever you might imagine. The Institute for Safe Medication Processes or Practices in Canada is sort of non-governmental body. We are funded by mostly the federal government, the national government, but some provinces as well. We're independent, we're not for profit, and we look to help fix the system. Things that get medications made, the things that get medications delivered to patients, and the way that patients themselves take the medications, and the way we monitor the effects of the medications, good or bad, hopefully good. So we work on the whole system, and we work mainly at a systems level for this. And what helps us really work is incident reports. So errors that happen, either errors that don't happen, that were caught just in time, that are able to come to us, and we can use those, learn from them, come up with some hopefully decent recommendations and broadcast them and disseminate them out. So what we really want to do is reduce the number of system vulnerabilities and facilitate improvements. So I don't get any pharmaceutical funding and no conflicts of interest. And humans are really good. I mean, we deliver most of our healthcare, positively, satisfactorily, quite safely, actually. We do a lot of good for a lot of people. But unfortunately, sometimes things break down. Okay? And it's sometimes related to how humans are put together or how the systems around humans allow, not terrific things to happen. I am the set of humans, so I am fallible. I do make mistakes. I misspeak sometimes. So if something is not clear, if I say something that, you have a question about, please stop me or come see me after, and I'm happy to answer or help you out or correct myself. So I am from Canada. So I'm from the northern part of the pink spot, or pink province called Ontario. And I was born in a small mining community called Kirkland Lake. And it's a sort of resource forestry and gold mining. And like other places around the world, and I think New Zealand as well, there's less people living in communities like this. They're sort of moving towards urbanization. So it's still a nice place, though. And I was not born at the mine when someone asked me the other day. I now live in Toronto, which is the sort of bottom part of the pink area, the central province of Ontario. Toronto is the largest city in Canada. It's about 5 million people. It looks like this at night. And I had an opportunity to walk. I had spent a few days in Auckland when I first arrived in New Zealand, and I had some time to wander around the city, and I thought, this seems sort of familiar because this is what Auckland looks like at night, so it's almost the same place, really. And then the next morning came up, I walked around again, and this is sort of what Toronto looks like in the summer, and this is what Auckland looks like in the summer. So it struck me as a very comfortable place and eerily similar, although, as I mentioned, our tower is much, much taller than Auckland's tower. So in healthcare in Canada, it gives you a little sort of perspective of what sort of our group deals with in Canada. So there is a federal body that's called Health Canada, but they only really have jurisdiction over medicines and devices. There's really 18 healthcare systems in Canada, one for each province, one for each territory, and some for the military, for the Royal Canadian Mounted Police, for immigrants and refugees. So, and again, a lot of those are broken into small structures. The big thing we miss really in terms of the socialized healthcare model is medications, okay? There are various little programs to help people afford their medications, but we don't have universal coverage. Yeah, so Health Canada does the medications and devices. All the provinces and territories, all the other systems look at the practices of medicine. So they regulate the practice. So sometimes it's very difficult to influence change because you have to influence so many different organizations and bodies. This a bit about me, or mostly about the things I'm not. I'm not a pharmacologist or a pharmacist. I'm a GP by nature, so I've done a lot of work in a number of various places. I use the term drug to equal medicine to equal medication. Okay? In Europe, and maybe the case here, when drugs have that negative connotation. So don't be alarmed if I use that. I'm a simple man. Okay? I'm not a smart man, as Forrest Gump might say. I like to simplify things that makes it easier for me. And I hope it makes it easier for you. I'm a medication safety enthusiast. So there's no credentialing for medication expert. It's just people who are involved with medicine somehow that really take an interest in trying to deliver things safely. So I am that person. I'm an enthusiast. I don't consider myself an expert, but I have lots of experience in it. And I learn new things every day. I've been learning as I've been going along in New Zealand about medication safety, how you do it, how it's different than what we do, what your sort of next steps will be, and it's fascinating to me. So thank you to all of you here today and all the people sort of who brought this thing together. We'll go through introduction. We kind of went through some errors and why we make them, some numbers a lot of you will all be familiar with. We'll take a break somewhere around the middle. There'll be a few exercises for you to do as well. And after the break, we'll talk about sort of, once we increase our understanding of humans, what can we do to make the system better? So no one goes to work intending to harm someone. In that patient safety video there, all the people who ended up giving ciprofloxacin to that gentleman, nobody really wanted to harm this person on purpose. But the world conspires against us. So sometimes things happen in the system that really, make it easy for us to make mistakes or allow the mistakes to go through and cause harm. So the world conspires against us, and the world and ourselves and how our brains work and how our systems are set up around us and how we feel, they sometimes conspire against us. And this is just a picture coincidental that it's ciprofloxacin. But this is a problem in Canada, particularly amongst generic brands. So
these are two types of antibiotics. They both start with C, they both end with CIN, they both have roughly the same number of syllables, they're both 500 milligrams, they're both in the same trade dress, which is the coloring of the company. The company's design is blue, it's by Ranbaxy, both of them. And when you open up the top of the container, they both are little round white pills, like most medicines that we take. So you can understand how people can select the wrong one. So this is what we mean by the world conspiring against us. So sometimes things are set up to make it much easier to make a mistake.
So this is sort of how the things we would work on. So this is the system conspiring against us. And what we would suggest to a company like this, well, make things a little bit differently or store them apart from one another or make them give them much more discriminating power so that we're more likely to select the wrong one. And this is what we would call a look-alike, sound-alike problem. So it makes it easy for you to pick the wrong one. This is also a look-alike, sound-alike problem. And so I often give a similar talk at Christmas to pharmacy students. I always add this in. So they all look alike and they all certainly sound alike. So I hope no one selects the wrong one. So some numbers on error. A lot of this is US data because they seem to keep better data than in Canada. Breast cancer deaths in 2013, 40,000. Lung cancer deaths, 160,000. Automobile accidents, 35,000. So this is just to put the healthcare error deaths in context for you. And if you prefer graphically, this is what it is. Healthcare deaths, anywhere from over 100,000 to 180,000, and even, as some people might suggest, up to about 400,000 a year. So the Institute of Medicine in '99 estimated about 100,000 deaths from preventable medical mistakes. So this includes medication error, but it's not only medication errors. Health and Human Services, U.S. body, about 10 years later, closer to 200,000 deaths. And John James published a paper in 2013 that, suspected 400,000 deaths a year from preventable medical mistakes. Now, there's lots of valid criticisms about these numbers, about how they're derived. And a lot of these are more estimates or modeling than actual counts, because it's very difficult to count some of these deaths due to whatever cause. But the point is, there seems to be a lot of them. Canada's had its own numbers, and about 7.5% of patients in Canadian hospitals are seriously harmed by their care. This was an older study now, at least 10 years ago. And we typically quote 10 to 20,000 Canadians die in a hospital as a result of medical errors. And a significant number are probably preventable. New Zealand, you have your own data, and you've done a few studies of this. 34.7 harms related to medication, and this is a nice one because it's actually related to medication error, or medication-related harm. So 34.7 harms per 100 admissions on the 2017 publication, and about 30 harms per 100 admissions in 2013. So about the same number, sort of before and later, and that's sort of typical of what we see in the US and Canada as well. Medication errors by themselves, about 24% of errors are related to medication or fluids in Canada. US, lots of big numbers, 400,000 preventable adverse drug events per year. That's preventable ones. In the outpatient setting, where I spend most of my clinical time now, it's, we know it happens a lot, although it's very hard because it's the great wide world. Sort of people self-medicate, and you don't know what patient is seeing what physician all the time or what healthcare provider, so it's very difficult to get numbers. The WHO put out a series on primary care, and they estimate anywhere between 12 to 50% of community prescriptions have some type of error in them. So that's it's a very wide range, and I think that reflects the difficulty in getting really accurate numbers, really useful numbers. So to put this in context with other risky activities or other activities that we do.
So the vertical axis, total lives lost per year. The horizontal axis, number of encounters for each fatality. So that's the number of times you have to be exposed to something to have a death happen. And in Canada, on the vertical, the number of lives lost per year. So for example, commercial airlines in Canada, including the small little ones that go in the very remote northern territories, less than 100 lives lost per year, and it's about it's about somewhere around 7 million exposures for each death. So that's the ultra-safe side. Scuba diving, there's not a whole lot of scuba diving in Canada. It's hard to get through the ice, but there's less than 10 deaths a year related to scuba diving in Canada, and it's about 1 in every 100,000 exposures to scuba diving that would result in a death. Some of the more industrial things that we do, mining, trucking, construction, sort of death occurs more often. So, between 1,000 and 100,000 exposures, and it results in a higher number of deaths. Rock climbing, driving, something most of us do, and typically the numbers over the years, although they are decreasing, about 10,000 lives lost per year in Canada, and about 1 in every 10,000 exposures to driving is your risk. So you may ask, where does healthcare fit in? Some of you, I'm sure, will telegraph. where it ends up. And so consistent with sort of the numbers, it's somewhere between 10 and 20,000 deaths a year, and between 1 in 500 to 1 in 1,000 exposures. So these numbers related to healthcare, may be a bit imprecise, but the point is that it sort of ends up on the sort of perhaps more dangerous side or riskier side of this graph. So you may sort of say, or you may leave here thinking, oh, healthcare is pretty dangerous, I should stay away. Well, comparison with other unhealth-related activities is somewhat unfair because we have no good safety denominators in healthcare. Unless you do a really robust study where you go through everybody's chart, it's hard to really determine what the denominator is. And certainly in voluntary programs like we have in Canada or a lot of other places, it's voluntary. So you're really not sure about how many things happen you don't know about, or how many repeat reports that you get, or sort of how even to classify denominator. Certain studies have used per admissions, per patients, per number of drug dose equivalents, and all those are interesting ways of doing it, but I think they don't capture everything altogether. As well, when we measure safety, we're actually measuring harm not happening, and it's a sort of a difficult concept to get across. So I liken it to sort of say, you can tell when lightning strikes, right? You can count the one lightning strike, but how many times does lightning not strike? So how many times does a bad thing not happen? It's difficult conceptually to really understand. So in some cases, it's very difficult to measure. As well in healthcare is we purposefully do pretty dangerous things to patients to try to get them better. So we give them poisons, we give them chemical compounds, which can be dangerous in order to try and get them better. We cut them open with sharp steel objects. We zap them with types of electricity. We fire lasers at them. We apply radiation for both diagnostic and therapeutic purposes. We knock them out and lie them down on a table, and we stick things in them. So you'd never get away with doing that with your best friend or anything like that. And in part, the risks of hospitalization belong to the original illness or injury that brings this person into the hospital in the first place. So no one goes to the hospital if they're feeling particularly well, right? There's no need. You're already in a vulnerable state the moment you walk in the doors or the moment you go to the clinic. So it provides a sense of vulnerability or a level of vulnerability that maybe not fair enough to compare it to scuba diving. And as an example, the risk of hospitalization or the risk of harm from hospitalization, certainly death from hospitalization, is small compared to almost risk of certain death in certain medical illnesses. But even if comparison to other activities is unfair, we know that mistakes happen, and we know we need to get better at preventing them. So this is a quote from Cyril Chandler, who was a pediatrician in the UK, and I like this quote. Medicine used to be simple, ineffective, and relatively safe. Now it's complex. It's actually, in a lot of cases, quite effective. And that complexity and that effectiveness increases the potential for danger. And we all have to work on all of these things together. We need more effective medications. I'm not sure if we want more complexity, but I think that's going to follow naturally. And what we really have to do is reduce any danger, reduce any risk of harm for people who come in to the healthcare system. Some quick definitions so that you understand what I'm saying, or so we're all on the same page. Adverse events, undesired, unplanned occurrence associated with the care services provided to someone in the healthcare system. It includes both preventable injuries and non-preventable injuries. So adverse drug event is the similar thing, but related to medications, but it also suggests the lack of intended medication as well. So if somebody's supposed to get a medication and you don't get the medication, that's a potential adverse drug event. And this includes both adverse drug reactions, the stuff that happens in the body, and harm from medication incidents, so things that happen sort of outside, and I'll go over that later. Medication incident is a potentially preventable injury from a medicine or lack of an intended medicine, and this includes near misses too, so things that might have happened had that error propagated to the patient, but it was caught just in time. An adverse drug event may not be preventable, like an unexpected reaction, some allergy that was heretofore unknown, or some sort of side effect, but it may be preventable. And in that case, it's possibly resultant from an error. And the medication incident, again, may cause harm and may not cause harm if it's caught in time. But a lot of times, something can be done to try and prevent something else from happening or the next one from happening. And a near miss, which sometimes in Canada we call a good catch, is something that could have happened again, but did not, because somebody realized something or something in the system prevented you from doing the next step or delivering the medication to the patient. And through timely intervention, the event did not reach the patient. So what happens when errors occur? These are just a few real cases that we've worked on, and we'll revisit a number of them later on when I go through cases. 9-month-old baby brought to the emergency department with fever and ear pain, probably an ear infection. Was given hydromorphone, which is an opioid narcotic. It's about 5 to 8 times more potent than morphine. So it was given hydromorphone intended for an adult patient. Thankfully this was realized, and sort of rescue interventions were undertaken, and things worked out okay. A 69-year-old man receives hydromorphone, 10 milligrams instead of morphine 10 milligrams, after an emergency department assessment. And unfortunately, this fellow dies in the family car on the way home. So medication error. An elderly patient, this is my patient, one of my patients, suffered respiratory distress, confusion, ended up in the ICU for a long time after receiving an unintentional 10-fold overdose of clonazepam. So these are all errors that do have the potential for being engineered out of the system. So why do these happen? Why do mistakes happen? This is James Reason's Swiss cheese model. And the red arrow is a trajectory of accident opportunity. So in our systems, in ourselves, there's ways to prevent errors, whether it's through attention, whether it's through focus or double reading or double checks or something in the system like electronic devices or other processes or procedures. They're not perfect. As Alan mentioned earlier, in the video, I don't know if we'll ever be perfect. So sometimes errors will propagate through the system. So defenses against error are imperfect. The holes in defenses vary in size and position. So if you're at the start of the shift, your attention, your energy might be, really sharp. You may focus really well. If you're towards your end of your shift, your end of your working day, you may not be as attentive, and that hole then becomes bigger. And when the holes line up, there's a trajectory of accident opportunity. And a nice non-medical example of this, how many things can go wrong, or what the Swiss cheese, what the holes in the Swiss cheese, is the Lac Megantic Disaster. So this is a train disaster in the French-speaking part of Canada, in Quebec, where a runaway train ran down, I think it's roughly a 15-kilometer route with no operator, and hit this village called Lac Megantic, and derailed, caused an enormous fire and explosion, and as you can see, leveled most of the downtown business core. So the Transport Safety Board of Canada did a really fantastic review of the disaster, and really sort of paralleled what we might do at ISMP Canada with a medication error. And this is sort of how their findings fit into the Swiss cheese model. So I just took samples of a few of their findings. So, handbrakes are part of the the Swiss cheese. They're part of the errors against defense. So when the train was parked in the evening, the operator, the single lone operator, had to apply sufficient number of handbrakes to keep the train still. And you have to test the handbrakes, test the effectiveness of the handbrakes by trying to move the train. So he did that. He applied a certain number, I think it was 7 handbrakes, so the things that you turn and it locks the wheels of the train. And then he went to test them. And he tested them, but the train didn't move, so he thought it was good. But the problem is that you're supposed to test the handbrakes without the air brakes on. But he had left the air brakes on. So he tested them with the air brakes on, and that overestimated the capacity of the handbrakes to stop the train. So in reality, the handbrakes were insufficient to stop the train or keep the train still. So there's one big hole in the Swiss cheese. The way the process was set up and the way of double checking whether the air brakes were on and off was not the best way to do things because of the managerial culture or the workplace culture at the train company or at the railway. And so appropriate supervision, which might have caught this inappropriate way of testing handbrakes that happened recurrently, was not there. So that's another hole in the Swiss cheese. The practices of only having one operator, no other train or railway company in Canada ever did that for reasons of cross-checking and double-checking. So these types of practices of allowing only one operator was another hole in the Swiss cheese. Things would have been okay if the air brakes continued to function. However, the air brakes were shut off because there was a fire in the main locomotive as the train was parked. And so the local fire department and another operator who was not the original operator came to put out the fire and in the process shut down the locomotive. So there was no air brakes left. So all was holding the train together or in its spot was an insufficient number of handbrakes. Now the fire in the locomotive was due to mechanical soundness. So there was a non-standard repair 3 months earlier because the company did not want to wait while a part was being shipped from somewhere else to get the locomotive back on the rails. So the repair was sort of jerry-rigged, which left a little bit of leaking oil, which finally caused a fire, which resulted in the shutting down of the locomotive, which bled the air brakes out, so they were no longer functional, which allowed only an insufficient number of handbrakes together. And so the train started moving, which would not have resulted in this disaster if the train was parked on a spur line or a sideline, but or a spur sideline that had derailleurs or track ends, which they all do in Canada. So it remained parked on the main line because it was felt that it was always easier to start up the train and just take off quickly in the morning after or at the next shift. It was parked on the main line. So it was left parked on the main line, so that sort of final piece of Swiss cheese that might have stopped this, that had a big hole in it as well. So all these things, any one thing here probably, or any couple of things in combination would not have allowed this to happen. But there was all these big holes in the Swiss cheese, and so this happened. And the Transport Safety Board did a terrific analysis, and they looked at lots of different things. And you can see all the sort of contributing factors from the railway itself, some from the locomotive, but also even as high as Transport Canada, the regulatory board, all these contributing factors across a number of things that led to this disaster and that led to this. So in healthcare, we return to this, and This is changing, thankfully, but we often think of pharmacists, nurses, physicians, whoever is there. We're expected to function perfectly all the time. So that's sort of the old thinking, but it's still prevalent. We're supposed to catch our errors. We're supposed to be, somewhat infallible. We're supposed to be the Swiss cheese, a big solid block of Swiss cheese. But we know that humans are not perfect, and humans have limitations that impact performance. So that's a good segue into our first exercise that I'll ask you to do. So these are Breezhaler inhalers. You do have them in New Zealand for probably about a year. They've been around in Canada for close to 3 years now, or at least 2.5. So I have two. I'm going to ask you I'll give one to a few tables and pass them around, look at them. You can open them up. You can sort of try and figure out how they work, see how they work. If you know how they work, you can teach the rest of your table. And think about, what it's like to use them. And we'll come back to that after the break, and we'll do a little exercise with them. So I'll pass these out. So why do incidents happen? Once we termed human error, we all sort of understand what that is. It's less human error than sort of our normal behavior, or on the spectrum of normal behavior and performance. So we know we're going to forget our keys sometimes. Okay, is that an error, or is that just what we do as how we're put together? We behave in certain predictable ways, and we have predictable limitations. And we'll spend some time exploring some of these human limitations. And we have limitations in memory, attention, communication, cognitive bias, interruptions. Our judgment, our decision-making ability is sometimes hampered in lots of other areas of performance. So I'll ask you, where was I born? Does anybody remember? Okay, what if I do this, if I try and trigger your memory? You'll all pick Kirkland Lake, right? Yes, good. So a lot of you got it the first try, some of you got it afterwards. So memory, our capacity is not small. We can work with a finite number of things at a time. We can remember a finite number of things at a time. And a lot of us will keep lists, we'll keep electronic lists or whatnot, or we'll constantly refer to what we have to do. It's time limited. So if I asked you where I was born right after that slide, you would have stood up and screamed Kirkland Lake. If I ask you tomorrow where it was, you may not even realize I was here talking to you. It's very context specific, so in certain instances you'll remember things that you wouldn't remember anywhere else. It sort of fades over time, it changes over time, so sometimes you realize you forget being somewhere, or you forget the people who are around you. You forget certain instances, certain aspects, certain facts about what actually happened to you or what you're supposed to do. It can be triggered by things like that, by having lists or by having other things, or if you hear a song, you might remember something from your past related to that song or smell something. Memory is certainly influenced by anxiety, by stress, by things like catecholamines and mental state as well. Your attention is finite, right? If you're focused on one thing, it's really hard to focus on other things, or you're going to miss something. And if you can imagine in healthcare how many different things we need to focus on, how many different things we have to pay attention to when we're engaged in a task, or how many things, conversely, how many things might we miss or not pay full attention to because we're focused on something else. So attention is a big factor in healthcare. It's a big factor in healthcare mistakes. So if you can help people focus a bit more or remove distractions, it's really a useful strategy to decrease errors. Communication, we have trouble with communication as humans. As good as we are at conveying thoughts and ideas, sometimes we mishear things, we misread things, we misunderstand. Our writing is not all that good. It's changing a bit, so now my typing is not all that good. It's very contextual as well. I'll give you some examples of this. So who wants to try this one? Yeah, I don't know. I've never sorted that one out. This one was reported to us a few years ago. Does anybody want to try this one? Okay, Coumadin 8 milligrams daily. And yeah, that's what the pharmacist thought it read. And that's what I thought it read too. But this was actually an error. So I'll give you a second shot. This is an anti-diabetic drug that's really not on the market anymore. Yeah, Avandia, 8 milligrams daily. So this is how handwriting can really foul somebody up. So, and you can imagine Coumadin, an anticoagulant, and Avandia, an anti-diabetic or an anti-glycemic medications. They're very, very different. So you can see how this causes harm. But you can also appreciate how easy it is to pick one over the other. It makes total sense that it's Coumadin. It's a reasonable dose, higher side, but still within the realm of possibility. We use abbreviations a lot in healthcare. Maybe we shouldn't. MS has a number of different abbreviations. These are sort of just ones I came up with on the spur of the moment. But they mean entirely different things, right? So the context in which you look at an abbreviation or the people you're speaking with, MS may mean something entirely different. And healthcare is full of acronyms. We can't go 2 sentences without an acronym. And one of the nice things about being a GP is you get to talk to a bunch of different specialties. And one of the interesting things I've realized is that ACEI to a cardiologist is an ACE inhibitor, an angiotensin-converting enzyme inhibitor. But if I'm using that same abbreviation in the presence of a psychiatrist, they will interpret this as an acetylcholinesterase inhibitor. So again, those are 2 very different medications. We have in healthcare a big lack of standardization. So, arguably a lack of precision. Or another way to put this is we have a lot of different ways of expressing the same thing. So these are all, either prescriptions or orders, prescribing orders, and these are all really the same drug at the same dose. So this is morphine, 10 milligrams twice a day. All of this would be filled by any Canadian pharmacist, and they would know what I mean. But having so many different ways of expressing the same one can lead to error, and this is particularly important as we move to electronic prescribing, electronic things. Humans can interpret this, our fuzzy logic. We can figure out what it means, but it's very difficult for machines to understand what I'm trying to write, or you have to have an enormous database with all these various ranges of possibilities that map onto a single standard equivalency. So we think technology sometimes is the best, and we still do a whole lot of faxing in Canada. And this is a fax received in pharmacy. Anyone want this one? Just yell it out. Yeah, so heparin, 15,000 units daily. Okay, so that's what was received in the community pharmacy. And they started to fill it, but they thought, well, 15,000 is not, the typical one. It's not a, totally unreasonable dose, but it's not the typical one. So I'm going to phone back to the hospital that faxed this to me and see if that's what they really meant. Or maybe there's an extra 0 in there or something. And when they phoned the hospital, they said, no, it's not heparin. It's dalteparin that we ordered. So dalteparin, 15,000 units daily. And you can see that this is in the pharmacy, and this is the fax, the original fax or the original order. That DA at the start, for some reason, got cut off. So if you sort of imagine the DA being covered, it looks just like heparin. So you can see that, this is handwriting partly, but this is also the problems occasionally with technology, with fax machines. We also, in communicating with one another, we have this lack of precision. We're sometimes not clear. And when we're like that, there's degrees of ambiguity, degrees of freedom in interpretation when we do this. And so this is a bit of an ambiguous statement. And this is, perhaps even more ambiguous. So we sort of understand what they mean, but it doesn't come across, exactly what they mean. And this becomes a problem with ambiguity if we're not precise or we don't use the clear language that we should. So this is a common order you would find in a Canadian hospital for hydromorphone. We use a fair amount of now. 2 to 4 milligrams subcutaneous every 2 to 3 hours, PRN, pro rata, as we need to. And when I talk about degrees of freedom, it's sort of with each component, and I'll explain that. So hydromorphone, there's no degree of freedom there. Say, that's the drug, hydromorphone. You're only allowed to choose that. 2 to 4 milligrams is a degree of freedom. So you can choose 2, you can choose 3, you can choose 3.7, anywhere between 2 to 4. So that's a degree of freedom. The root, subcutaneously, under the skin, no degrees of freedom. Okay, it's under the skin or no other way. Every 2 to 3 hours, so 2 to 3 is a degree of freedom. It could be 2 hours, 2 hours, 59 minutes, somewhere in there. So that's 2 degrees of freedom. And, PRN is pro rata, whenever needed, and that's whenever needed is a degree of freedom. So whoever's deciding or whatever the patient decides, however that's worked out, they can choose to have nothing or some dose. So 3 degrees of freedom in there. I don't have a good answer what's a good degree of freedom, but I'll show you the problem if you have too many degrees of freedom. So in this case, you can get nothing, right? So you could conceivably get 0 milligrams in 24 hours if whoever's deciding or whatever you decide doesn't need it. Or if you're less conservative, you can get 4 milligrams every 2 hours, which is 12 times a day, which is 4 times 12 is 48. 48 milligrams of hydromorphone for 24 hours. And if you prefer morphine, to give you a sense of what it is, it's 0 to 336 morphine equivalents per day. So this is enormous range, right? And I'll show you a case this afternoon of degrees of freedom causing problems. So 0 to 336, that's a huge range, and you sometimes run into trouble with this. There's no limits in here, it's a bit imprecise, and there's a bit ambiguity to interpretation. How much do you actually give? We'll spend the next few minutes talking about cognitive biases. Humans are pattern-seeking animals, okay? We look to make things easier for ourselves, and we've developed these pathways in our brain that help us interpret things, but sometimes it sort of tricks us up, depending on what's around. And there's really hundreds of cognitive biases. This is a poster that I have at my office. It's 20 cognitive biases that screw up your decisions. So it's a nice little poster that I look at, and I often will sort of take out elements of it and sort of think about how it affects me. Framing perceptual bias. So that piece of information in the middle there is a 1, 3, is a 13, or a B, depending on what the environment looks like surrounding it. So your brain is quite comfortable with that. You have some more framing perceptual and expectation bias in here. So this does not say Paris in the spring. This says Paris in the spring. So you're jumping, that's your brain jumping to conclusions, working ahead. So this, you can all sort of read this. So you can read this despite the fact that really it's gibberish, right? The words are, except for the first and second letter, they're arranged in random order. But your brain is able to, it thinks it's a letter, it wants it to be an English word, so it automatically just jumps. And it also depends on the context. So you use the context of what the sentence looks like to make that even easier for your brain. So this is sometimes, yes, it's helpful in cases like this, but it sometimes can trick you up. So that link there at the bottom, if you Google Matt Davis, he has a lovely explanation of some of that. So you're more likely to be killed by a shark, A part off an airplane or a vending machine? So who says vending machine? Okay, who says airplane part? Nobody? Shark attack? All right, so a bit more shark attacks now. Usually in New Zealand, your colleagues have been saying vending machines. The answer is actually fallen airplane parts. So in North America, people always pick sharks. Guaranteed, you can put $1,000 on shark. People will pick a shark. Because shark attacks make headlines, they're in the newspaper for a few days, they lead the evening news on TV. So that's availability bias. So we're more exposed to it, so we think that's the truth. Confirmation bias, seeing what you expect to see. This is a big packaging and labeling problem, so I expect this to read morphine, but it actually says hydromorphone, so I pick it. Anchoring bias is usually attending to the first piece of information. This is a problem particularly in drop-down box selections, so you're often going to make a mistake with the first element in a drop-down box. Technological bias is favoring information presented over a computer over other handwritten information, and we'll talk a bit about this later. We'll talk a bit about technological complacency bias. Cognitive ease is changing our problem to an easier one. And is my Prime Minister an effective leader? You have a new one. Or do I like my Prime Minister? Do I like my Prime Minister is a much easier question to answer, so you may answer the real question in that way. So we'll take a break there. We'll resume the second half later.